Sort of geeky humour. Hey, welcome everyone. My name is Ben Buchanan. I'm sorry that my video doesn't seem to be working today. And this is Dr. Nathan Castle, the Chief Science and Evaluation Officer at Novopsych. We're going to be talking today about how clinicians can implement routine outcome monitoring to hopefully improve the outcomes of clients. So Nathan, I'll let you go ahead.
Well, I'll jump straight into it. Thank you, Ben. For today, learning about putting routine outcome monitoring in your practice, there'll be three main learning points. One, considering why measuring client outcomes can help you and your clients. Two, learn how to introduce routine outcome monitoring, or ROM, as you'll hear it said today, to clients and give them meaningful feedback. And lastly, to introduce an easy-to-use model to answer the simple question, are my clients getting better? The first thing I want to talk to people about is evidence-based practice versus practice-based evidence. Evidence-based practice is really what we learn primarily in university in our training programs. So essentially, it's being able to apply research findings to what we do in everyday practice. So the research findings are developed from rigorous trials, often with a lot of participant exclusion criteria. So for example, if it's a trial about depression, that client who also uses cannabis or has an alcohol dependence certainly wouldn't be in that study. And the research evidence provides information about the general efficacy of a treatment approach for that disorder. The evidence-based practice is a necessary, I can't even say it, it's necessary, but it's not always sufficient for a evidence-based mental health provider. Published literature provides high quality data, but sometimes, depending on who your client cohorts are, it might not be as relevant. So this is in stark contrast to practice-based evidence. And you can see here that it has four very different pillars. Practice-based evidence is the use of data from your own practice to create a body of evidence which can inform client care, like your therapy. Evidence is developed via the systematic collection of outcome measures associated with some kind of treatment goal or outcome. So in other words, that's what we would describe as routine outcome monitoring, which is going to be a core of what we're talking about today. This provides evidence about the effectiveness of your treatment in the real world. For example, that client that had depression, but also might be using cannabis or having an alcohol dependence, getting an insight about your effectiveness with all clients, whether they're getting better or not, and being able to test hypothesis as to why that might be occurring. Practice-based evidence is personalized and relevant, and therefore can be very useful to empower clients as well as clinicians. Now we're going to actually look at what is routine outcome monitoring. So it's systematically assessing the individual's client progress or outcomes using standardized outcome measures. These are things like the DAS or wellbeing measures. In this example here, we've got a client who's asking, so what are the results of my social anxiety levels at the moment? You know, thinking about this, say 8, 10, 12 sessions during treatment. And the clinician's actually able to say, based on the results of this social anxiety measure, your results indicate that your anxiety or social anxiety has decreased to a level consistent with individuals who are not impacted nor require therapy. Is this consistent to how you feel? And should we look at finishing up the therapy or the work here if you've met your goals? So this is a really nice integration of the results of someone with social anxiety and their progress across treatment. Importantly, it doesn't make the decisions for you. You need to collaborate with the client and find out whether that works for them. I'm going to throw over to Ben and go over to the next slide now.
Cool. So lots of people ask me when I'm talking to them about routine outcome monitoring. The main question is, which questionnaire do we use? What do we do? And I think there's no one simple answer. Certainly the most used routine outcome measurement within the NovoPsych platform is the DAS. It's widely popular in Australia in particular with Australian psychologists. And I think that's the reason why it's popular is that it is measuring, well, 3 really high prevalence problems: depression, anxiety, stress. And so on the screen now, you can see a graph of some outcomes from the DAS, where someone's been administered firstly in Feb, then in March, then in April. And these results are presented as percentile ranks, showing, and any score above the 90th percentile is deemed to be of clinical significance. And so you can see at the start of treatment for this person, they started really bad, feeling depressed, feeling anxious, feeling stressed, and then they progressively got better until April, where depression and stress went down, but anxiety went up. And so that's interesting because it gives us some hypotheses about, all right, well, why are you overall getting better? But what's different about the anxiety, which is perhaps different to the other elements that you're experiencing? If you go to the next slide, this is a graph of a patient of mine. So this is a typical example of how we might use routine outcome monitoring. So I've been seeing them for a long time, started seeing them in July of 2018. And you can see from July to 2018 to January of 2019, this person was so depressed. They were just so depressed. And then something happened in February. They got better. And me and my client, months after February 2019, we're looking back at this and we're saying, hey, why did you get so much better in February of 2019? And I said to him, look, I think it's because you got a girlfriend. I think that you got a girlfriend and then life started to feel good. You felt your self-esteem was going up. You started to spend more time outside. But he was like, no, I actually got a girlfriend in January. And I think what it actually was I decided that I wasn't going to study law in February. And for this guy, he was highly perfectionistic, had unrelenting standards, and law was a symbol for him. He was at university and it was a symbol of him of potentially his parents' values. And so that decision to not study law was incredibly empowering for him. And so we were able to piece it back retrospectively and say, well, that's one of the key reasons that you had this change in mindset around studying law, which allowed you to make that decision, which improved your mental health. Can you go to the next slide, Nathan? So we all know the K10. The K10 is often used by the GPs in mental health care plans. And it's probably, I would say, probably the most hated scale in Australia. People don't find it particularly useful. But there are lots of psychologists that use the K10 routinely on NovoPsych. And again, NovoPsych will graph the treatment over time. And if you click to the next graphic, Nathan, one thing that NovoPsych does, and I'm very proud of, is it actually uses the K10 to break symptoms down into 4 different symptom clusters. 2 primary ones, depression and anxiety, but also negative affect, fatigue, agitation, nervousness. And so if you do use the K10, this is really great because the most boring measure in the world suddenly becomes a little bit more interesting in that we can delineate between different symptom clusters and again, feed that back to clients to say, hey, it sounds like the anxiety is heaps worse than the depression at the moment. And Nathan, if you can go the next one. Some psychologists don't want to focus on symptoms. So when they're asking me about what measurement they should be using with their clients, they don't want to use the depression, anxiety, stress scale. They don't want to use the K10. They want to use something that's more positive, more thinking about well-being. And the personal well-being index is a great measure that measures 7 of the most important areas to life. And this measure was created by the World Health Organization and is used cross-culturally around the world. But I find it pretty useful for some of my clients as well to get a bit of a sense about how they feel their life actually is. And then finally, next slide. Oh, this is the graphics of the personal wellbeing index. So you can see that this person, in January of 2021, they felt like their security was really low. This is a client of mine who had been severely impacted by some domestic violence, and also COVID had really put a complete mess in terms of her life. And you can see that reflected here, and then things improving. So the higher the score on here, the better they are. Next slide, please. One of my favorite questionnaires, and I want to spend a bit of time on this, is the valuing questionnaire. This is particularly helpful for people who are into the ACT framework. Some of the measures that we use, the most typical measures are like the symptom ones or the general wellbeing one. But if you're working in a particular modality, then you can tailor the assessment for your needs. The valuing questionnaire measures 2 things. It measures progress, which is defined as enactment of values, perseverance, and including clear awareness of what is personally important, and obstruction, which reflects the disruption of valued living due to avoidance of unwanted experiences, distraction from values by inattention to values, or undue attention to distress. And so in the ACT framework, these 2 conceptualizations are really important.
So, what activities do psychologists take part in that improve client therapy outcome? Obviously, as part of our profession, we have a lot of regulations, a lot of guidelines that we have to follow, and we do many hours of professional development each year, at least 30. From that, we go through learning content, trying to understand theories, models, and skills. We learn the methods of how they're applied, either by attending a workshop or having, a very skilled person kind of role model some of these things to us. We also do a lot of supervision. What I find particularly alarming, I guess, about the research into all of these areas is that in terms of what they do for client outcome, none of these activities actually improve a client's outcome. And you might think to yourself, well, how can that possibly be? We're learning new techniques, new treatments, new methods. We are talking about that client directly, Chris who's got depression, or Sally who's got OCD. We're formulating, we're looking at the perpetuating issues, all these things. How is it possible that that's not impacting the client therapy outcome? And largely, while the mechanisms are still under research, largely it's because the client's actually over here when all this happens. The client isn't with you during any of these times. They're being talked about, rather talked with. Obviously, the client can't be in your supervision session. And none of these areas have client feedback integrated as part of it. The client isn't able to tell you when you're talking about them in supervision or formulating, that part's not right, but that part is. Or when you're doing your schema training or your DBT or anything, when they're talking about a particular skill set and you're thinking about this client in mind, and the client goes, but I don't like mindfulness or whatever it may be. So what ends up happening is that we get all these learnings, and then we start to apply it without integrating the client in that process. And largely that gap is where much of this research is coming from, without impacting the client outcome. So what can we do? It's not all doom and gloom. What actually changes is being able to monitor and routinely understand how therapy is progressing. Not because it's magic, not because it does something that these interventions don't do, but in fact, it's similar to when you go to your GP, you're not feeling well, and they'll take some kind of baseline metrics. How's your temperature? You got a fever? How's your heart rate? Is it elevated or too low? How's your blood pressure? All these things give you indications of where the patient in those settings, medical settings, but for us with an outcome measure, where the client is in therapy. Are they getting better quickly? Are they getting worse quickly? And all this information can be used to have a collaborative, in real-time discussion with your clients about what needs to happen in treatment for their well-being to go up or distress to go down. Put simply, there's 3 stages that hopefully after this training, because here's the irony, you're in training, and if you do nothing from outside here other than think, well, they had some tech issues, but Nathan and Ben have a lovely voice, then nothing's going to happen with your clients. If you take away these 3 pivotal pieces of information and then start to apply them, then you're more likely to have an improvement in your client outcomes overall. So number 1, choose a measure, choose an outcome measure. There is no best one. Sometimes we are perfectionists and we go, what is the absolute best one? For my mind, think about what you bring to therapy, what you in your kind of professional identity think you do in therapy. Are you someone that believes that they improve well-being? Awesome. We've got a well-being measure that you can use. Are you someone that thinks that you decrease distress? Then go for that distress measure. Or are you someone who thinks that you are changing things particular to diagnosis, which is very valid too? If so, OCD measure, borderline personality disorder measures, anxiety measures, the list goes on. And of course, if you really want to measure the alliance, you can do that too. Then choose your frequency. And this is where the routine part of routine outcome monitoring comes in. You heard what Ben does with his frequency. You heard what I do with my frequency. There's not a magic number with frequency either, but what does matter is that you decide the frequency and you stick to it. You know, Ben doesn't decide for some clients that he does it every session, other clients he does it every 3rd session, other clients he does it every 10th session or not at all. Because what ends up happening is that we start biasing all the results. So choose your frequency, whatever works for you, whether it's at every Medicare review, whether it's at every session, whether it's every 2nd session, what works for you. And then choose to stay the course. What inevitably happens with anyone going through this endeavor is they get the logic of it, they understand the research, but there can be implementation issues. And that's, you know, the belief that, oh, I'm a bit tired, this is going to make the session harder. Often it actually makes it easier. It actually gives you the direction to go in. Or it might be that this client's fine, they don't need to be kind of checking in on their therapy progress. Any of these thoughts that come up, or perhaps emotions that come up around anxiety, note them down, reflect on them, and try it anyway. And how to make it easy? We've really moved on from the paper and pen days. And importantly, our clients have too. Our clients, I think, have come to expect that it'll be digital if they're going to do it. And the benefits of using NovaPsych is not only that you can choose your measure from 50 odd measures that are out there to make sure that it fits for you, rather than you having to do the work for the measure, but it also means that all the results are instantly interpreted. The scores are there, what that means is there, and visually, you're actually going to get these nice graphs. And for my money, it's really the graphs that the clients respond to and can get instantly. And then, of course, the conversation that comes after that. So why do it? There's a few benefits that we can see from the literature and clinical observation as well, is that without routine outcome monitoring, you get higher rates of dropout. There's less objective evidence for the client around the treatment response, and also reduced therapy effectiveness overall. once you are implementing routine outcome monitoring, you've got it routinely, you've got a frequency that works for you, you've got a measure that you believe in because it's measuring what you do, and you use feedback with clients, you start to see that therapy becomes more tangible for the clients. The other thing is that the outcome monitoring can detect clients likely to drop out. This is when you start seeing distress measures rocketing or well-being measures going down, or if you're doing any alliance measures, that going down too. It also really helps to conceptualize issues. What is happening now and why? And that's a lot to do with the hypothesis testing that we talked about earlier and Ben showed with his own client. So importantly, we can see here that engaging the senses is part of this. Seeing is believing. Almost 50% of your brain is involved in visual processing. 70% of all your sensory receptors are in the eyes, and you can get a sense of a visual scene very quickly. This is why the graphs and the visual representations are, I guess, priority as the data gets interpreted. For many of the people that I train in this space, dropout seems to be the one thing that pulls everyone in. At the end of the day, we work really hard and we want the best for our clients. I don't know about you, but sometimes I have a client that's coming in and I'm thinking, oh, I wonder how they're doing. I hope we can get this work done. I hope they're meeting some of their goals, and I might get an empty seat. Dropout. It's a hard pill to swallow, not only from the point of your time, you've prepared and you're thinking about them, but also that sense that it could have been different. In terms of what routine outcome monitoring does to reduce this, first of all, clients can start to see the progress. Okay, so it's not intangible because obviously what we talk about is pretty complex stuff and it's so many things. So a simple way to measure their progress. Also, the therapy can be adapted based on the results. So suddenly, clients getting better, worse, or staying the same isn't so much of an issue because we know what's happening and we can adapt. And lastly, it reinforces pretty early on for those clients that are coming in and not too sure if this is a valid issue or if it's a real issue, being able to show them that they're in some kind of, say, clinical range or elevated with their distress. It's a way to validate them on what's happening. The other thing is, when you use routine outcome monitoring, you have an improved treatment response. So not only do we see that the client deterioration rates reduced by half, so in one study, went from 20% of clients on a caseload reducing to 9% just by using routine outcome monitoring, not by choosing the new model or the new techniques or having an expert coach in sessions, just by using routine outcome monitoring. Approximately 2 minutes out of every session, at times 1 minute. And enhanced effectiveness. We can see from some of these studies that the amount of effectiveness is improving by up to Cohen's d of 0.55. What is that, most of you are going to ask? I mean, I don't have data on my jumper for no reason. I love this stuff, but to actually interpret that into a way that makes sense, generally what it means is if you're an average psychologist, which most of us are, 80% of your clients are better off seeing you and are improving compared to a client that doesn't go to therapy. Now, if you add routine outcome monitoring and you get up to this statistic added to your effectiveness, what that practically means is that over 90% of clients that attend your therapy are better off than not attending therapy at all. So for my mind, that's a really big jump on those clients and effectiveness. So when your client isn't getting better, let's not leave that as the elephant in the room, because you're going to see that happen in routine outcome monitoring. Certainly, all the studies to date show that when we don't have routine outcome monitoring, us as therapists tend to feel that very few of our clients are getting worse. When we have routine outcome monitoring, because it is far more accurate, we can usually pick up those things. So when it does happen, what do? When it's just clinical observation, we only recognize it 21% of the time. When we use outcome measures, we're going to identify that 85% of the time. Importantly, that doesn't mean it's happening 85% of your caseload, but most of the time that it occurs, we will pick it up. So let's talk about what the benchmarks are for therapy. This is relatively new to talk about as well, although a lot of these benchmarks have been developed over the last 40 years. So the research isn't necessarily new, but they have conducted this in actual private practice settings. So this isn't from academia. This has been really applied in a private practice like yours and mine to understand what are the benchmarks, where do we want to hit in our caseload. The proportion of clients that are improving, we want to hit somewhere around 64 to 74%. The percentage of clients getting worse, we want somewhere in the area of 5 to 10%. So really acknowledging that this does happen for everyone. And the proportion of clients dropping out, 20 to 22%, 1 in 5. Okay, that's the benchmark. Importantly, what we do notice with routine outcome monitoring, this starts coming down. Average number of sessions, somewhere between 4 and 6. Obviously, that accounts for those clients that might come for 1 session and not come back. Also accounts for people who have been around for 20 sessions. And then the overall treatment effectiveness, again, there's that Collins D, 0.8. We now do outcomes analysis to be able to show people and give them a report on what their results are compared to some of these international benchmarks. And what we do have is my own. These are all my outcomes from the DAS-21, looking at Novopsych data. I used it for a number of years, put together all the information and was able to analyze that data to find out all about my practice, but more importantly, where to improve. So for me, I could go through every little angle, but for me, the things that I need to work on, particularly is my deterioration rates. 13% of my clients deteriorate. So that's an area where I can work on, similar to the kind of work that Barry McGuinness did with his dropout rates. And that my dropout rate is actually in a good range. Clients are generally pretty engaged. So deterioration has really been my focus for the last 1.5 years or so. We've also got Ben.
Yeah, hey, thanks. This is my data on the slide for all my clients with body dysmorphic disorder from 2018 to 2021. So I exclusively work with clients with body dysmorphic disorder. I don't really take on any clients with different presentations. And so what I did, I wanted to know, actually, am I any good at treating people with body dysmorphic disorder? Even though I may have studied it a lot and devoted, my clinical career to it, I still wanted to know, am I actually effective? And I think this is a really important process for all psychologists to do, to figure out, well, firstly, a niche to do, but then also gather data to see, hey, am I being effective? And what I found was that 69% of the people that saw me for BDD had reliable improvement. And by reliable improvement, there's something called the Reliable Change Index, which is sort of a statistical way of saying that they changed enough for it to be considered significant. It's more signal and less noise, if you will. And 0% of my people deteriorated, and 31% had no reliable change. And that equals a Collins D of 1.24. I then had a look at my own data and then compared that to the published literature from all of these, international funded studies on BDD, where they run through a particular treatment protocol and found that the average in a meta-analysis was 1.22 Cohen's D, which means that I'm slightly better than average at treating BDD, which I'm really pleased about. So go, yes. And so this is really validating for me, because well, I know that I'm definitely not going to help everyone, like absolutely not. And some days are really hard in that, you know, let's say you have a day and you've got a few of those clients that just aren't getting better and you're not seeing any change. And then your self-esteem as a therapist is sort of often dependent on the last client you saw. For me, coming back to the data and zooming out a bit and saying, all right, well, I'm helping 69% of the people that I'm seeing, definitely not helping everyone, but that's okay. That's as good as therapy gets. And I can afford to feel okay on that, is something that I find pretty helpful. For this, I use a particular measure called the appearance anxiety inventory, which is sort of a BDD specific measure, which also underlines the fact that we've got to be choosing the right outcome measure for the clients that we work with. Back to you, Nathan.
Thank you for that, Ben. And I can see many questions coming up in the chat, which is telling me that, you know, a lot of this stuff is very relevant, especially around benchmarks and practice-based evidence. So I can see there's some interest there, which kind of brings us to our next point. If people are interested in learning how to do this themselves, how to implement routine outcome monitoring, and to get a report based on their effectiveness, showing where they are and how their practice is running, how their therapy is running, please get in touch with me, nathan@novapsych.com. We're running an outcomes analysis training group. It goes for 9 weeks, but it's really like 1 hour of training every now and then to kind of check in with you as well around your progress, make sure you're implementing it. We're going to not give a workshop on one day and expect that you're off and to the races, actually checking in routinely with you across that course to make sure things are going okay and to uniquely problem solve any barriers you come up with, but importantly, at the end of that, be able to analyze your data and give you a report on how you're going. So please get in touch if that's of interest to you.